Good afternoon, Dr. Alvarez. Thank you for joining us for the Q&A session from the Ed Summit. Thank you, viewers, for turning in questions. We'll get started. This is the COVID-19 Q&A. People were wondering, is MS a comorbidity for COVID?
Yeah, so thank you very much for the invitation to come back and answer a few questions. So MS itself does not appear to be a comorbidity for COVID. The number of cases within MS patients appear to be the same as in the general population. And again, that applies in the US and some of the larger, some of the other countries that have large repositories where a lot of information is being gathered. So we feel pretty comfortable about being able to answer that question.
We've had a lot of questions from folks about different DMTs, wondering how long is it okay to postpone rituximab? Is it okay to start Ocrevus during this time? If you've been delaying, kind of when should you get back on your track?
Yeah, I think our messaging got a little bit confused, and you know, as we kind of keep updating our thinking and as we learn more things at the beginning, the very first ones of these updates that we were doing, we were recommending delaying some of the treatments for MS patients, particularly the B-cell directed therapies. So that would include things like rituximab and ocrelizumab. About now, seems like a couple weeks ago, we started to change our mind around this. And so now we're recommending that people proceed with their infusions as scheduled, as planned, as discussed with your provider. This had to do with a number of reasons. And again, part of that has been through the repositories that I just made reference to, that made us feel more comfortable that patients on these therapies appeared to do really pretty well, that we did not see an excess amount of deaths or ICU stays in patients on these treatments. I think we've all been touched by people that we know that have succumbed, died from COVID. And it's easy sometimes to kind of get afraid of that. But when we look at the large population type data and kind of looking at us as a whole, we're not seeing a big excess in the amount of deaths that we see in MS patients, and particularly in those on these kinds of treatments. A lot of the deaths have occurred on people on no treatment, on some of the treatments that we think are safe, that don't have much of an effect on the immune system, such as Copaxone or the interferons, almost as much as the medicines that we're a little bit more afraid of, such as these B-cell directed therapies or Tisabri or things like that. And based on that comfort, we started saying, let's just infuse as we normally are. It was creating a lot of confusion. And am I okay to push out? How much should I push out? And those kinds of things. The hospitals have gone to great lengths to make these infusions as safe as possible. And again, putting all that stuff together, I think allows us to feel really comfortable to proceed with the infusions as scheduled.
And can you just briefly touch on the difference between immunomodulating and immunosuppressing drugs? Specifically, we had questions on Vumerity and Mavenclad. Yeah,
so we've often talked about how immunosuppressive a drug is for MS. And I think the challenge is that we see that pretty much every medication is a little bit immunosuppressive and a little bit immunomodulating. That it's not like one medicine is completely immunosuppressive or another medicine is completely immunomodulating. Drug companies have kind of pushed some of these notions with the idea that immunomodulating medicines were safer, so let's call it that. And we can see that most of these medicines alter the immune system, and by altering that immune system, being immunomodulatory, that they tend to do that by suppressing the immune system. And it just has to do with how much and in what patient. So some patients really might drop their white counts a little bit more and might be more immunosuppressed than other patients. Some of the medicines might be more immunosuppressive for only a few days after a treatment, and then less so. So in the case of Mavenclad, for example, some of the cells start to come back after several weeks to months. And so outside of that, we would think about it as not being necessarily immunosuppressive, but in that first period of treatment, we would be a little bit more concerned about that. Vumerity takes some time to take effect, and so initially we may not think about it as being very immunosuppressive, but in some patients where they can drop their a type of white blood cell called the lymphocytes, if those drop below certain levels, we start to get more concerned about those medicines being immunosuppressive. And so the same drug may be more immunosuppressive again in some people than in others, and that is why we sometimes push to have more labs or less labs, because we get a little bit more concerned about the levels in certain patients.
I'm going to ask the question in just a slightly different way because I've gotten it a ton of different ways from patients. But just to clarify, you guys are not suggesting any specific disease-modifying therapy course based on COVID, but instead continue your discussions with your neurologist and what the
Correct, exactly. So I think I saw some specific questions around and I didn't quite answer the other question is, should I start this treatment? Yes, if that's what you discussed, you should start that treatment. Because of COVID, that should not influence that. The risk of MS, if you don't treat it, is really high, and so we should not delay, especially getting started on treatment. The idea of switching to another treatment because it might be safer with COVID, again, we're not seeing that there's a difference in bad outcomes between the different treatments. So we should not be changing from one treatment to another based on our concern for that. If we started to see that, we'll be the first people to kind of make some adjustments on how we treat patients. And some of those were, a little bit more theoretical at the beginning, and part of the reason why we started to, be nervous about it and suggest that delay in the treatments. But again, we're not seeing that. We now have, it seems weird to say, a ton of experience in this era for a virus that's been around for less than a few months, but unfortunately we do have that experience, and that's why we feel a little bit more comfortable making those kinds of statements. I think part of where things maybe come out is the concern. We do want to make sure that these infusions are happening when you're feeling well, that if you do have fevers or chills or runny noses, not feeling well, those kinds of things, that we do hold off on infusions. We've always recommended that in the past as well. We want to make sure that you're at your best when you're getting these infusions. And so that's one of those factors I think becomes important to think about.
And specifically talking about the CD20 B-cell therapies, is there any length of time, if somebody has been extending their, or putting off their infusion, is there any length of time where you would have to restart the 2 half doses, or will you just jump back into your normal dose?
Yeah, we tend to jump into our normal dose. That's an excellent question as to why we even have the split dose in the beginning. If it was up to us, we would get rid of it. Most of that second dose is really something that could be done almost in an hour or more. In addition to that first hour, it would happen really quick, but it kind of resets everything. It was initially done because there was a concern for infusion reactions. And we have not seen that bad of infusion reactions, again, as we get more experience. But unfortunately, that recommendation requires a change by the FDA, and lots of expensive studies to change it. And so I think we're kind of stuck with that. For patients, for example, coming off of rituximab or the other B-cell drugs, we skip that split dose if we can. And we sometimes have a little bit more leeway with certain insurance companies and certain infusion centers. So in our mind, really, the split dose is not very necessary.
So here in Colorado, at least, we are moving to safer at home guidelines. What does that look like for people with MS? You mentioned in your presentation that we should be getting outside, getting out of the house a little bit more. What does that look like to be doing safely?
Yeah, so yeah, I think this is a very important question. So I did not imply that people should go out and start socializing indiscriminately. I think it was a recommendation based on having people maintain their mental sanity and start interacting with people in a way that was safe. What I mean by that specifically is the virus is very easily inactivated by the ultraviolet light when you're outside. The wind blowing, things like this doesn't let the air droplets kind of hang out when you're talking to people. It's going to sweep those out a lot more than when you're inside, indoors, talking to other groups. It is not a coincidence that the cities that have been hardest hit are cities that have a high density of population. It's no coincidence that as the reopening has happened in other countries, that where we see pockets of spread happen in places where people are gathering in sort of very kind of congested type environment. So we see this, for example, with the example of the nightclubs in South Korea, where again, people are getting close together in very close proximity and indoor. And so trying to get outside is a safe way of doing a little bit more of that mental health. I think it helps promote the idea of exercise, of wellness. If you are outside and there's a lot of people, wear your masks. If there's nobody else around you, it's okay to pull that mask down a little bit. You have to be in contact with other people in order to really transmit the virus. It doesn't hang out in the outdoors that much. On the indoors, there's a little bit more concerns. You can drop it off in doorknobs and somebody else grabs that doorknob, not literally, but I guess touches the doorknob and could then touch their face. That's the recommendation around not touching your face. And so I think the idea is mostly work on your exercise, work on your wellness, try to keep active, leave the house, because at some point we just feel claustrophobic at home. And so trying to, at least see people from afar or other things like this can be very helpful. If you have a dog, take it for a walk. If you can talk to your neighbor across the fence, that's fine. Maintaining sort of that safe distance, where I live, it's not uncommon sometimes on Friday or Saturday nights to walk around and see people hanging out on lawn chairs, kind of like 6 feet apart, talking to each other with a glass of wine. Completely fine to do. I mean, it's just trying to keep, a little bit more distance than maybe we're used to, thinking about those things, not touching your face as much. If you're in an area that maybe after grocery shopping, maybe consider switching your clothes if you're worried that maybe somebody was sneezing on you or things like that. So those are the things where some of those recommendations kind of come in place. So be active, try to keep sanity. We started a family game night. We reached out to our family, and I tell you, I talked to my cousins more during this part than I think I've talked to them in the last 30 years. So it's a good time to kind of reach out to other people and try to bring some of those activities that maybe we weren't doing, or ways to connect to people that are a little bit farther out that maybe we haven't reached out to. I think it's a good time to try and do that.
We've been instituting some virtual game nights as well. It's pretty fun.
Yeah, and then Kelsey, the one part I forgot about was including the website for the Rocky Mountain MS Center. I want to plug that one in because there's a ton of activities. I've used it for my kids when I needed some mental sanity, to plug them and kind of have them do virtual tours of some random zoos or other things like that. There's a lot of websites and ideas on that website. So maybe you can kind of direct them through what tabs or how to navigate to that, Kelsey.
Yeah, so the easiest way is if you just go to mscenter.org, and then at the top of the page, there'll be kind of a banner for COVID-19 education. That's our general COVID page. And I think about halfway down, there's a link for resources. And that resource document actually covers, it's got a ton of virtual activities and fun things to do. It's also got a lot of resources like where to find food if you are experiencing food scarcity, kind of all the government websites for COVID information, how to volunteer your time. It's got a ton of different links on there. So I do encourage you to check those out. Speaking of web pages though, Dr. Alvarez, we had a couple of requests for updated graphs. And I wanted to say thank you. We'll be putting on a full COVID update next week on Thursday, May 28th. So watch your email for registration information from that. I'm sure we'll have lots of graphs for that presentation.
It takes the onus out of me to kind of have to come up with stuff if I can show data. So let me share my screen real quick and I'll bring those up. Let's see, I think, so just as a quick reminder, this is now being recorded on May 21st. So this is kind of the numbers for today. We just pulled these out and sort of the sites for these different models. So the IHME organization is the one that's doing a lot of the kind of national modeling and is kind of a lot of times referred to in the US for modeling at the different state levels and things like this. They keep adding kind of new cool ways to think about cases and things like this. So I pulled this one and I forget if we had this on the day of the presentation, but one of the neat things about it is that low bar is the numbers that I think we've been presenting. Those are the number of cases in Colorado specifically. You can look at the states, you can look at New York, you can look at all these other areas that you maybe might be coming from and kind of compare it to Colorado and kind of see when things are enacted. And so that tiny little bar highlights the area, the number of cases in the US. And another great place to look at that is on the bottom website at the Colorado Department of Public Health and Environment. This gets updated almost every day around 4 o'clock in the afternoon, so you can kind of see what the numbers are. Again, think about these numbers being about a day old, so, you know, kind of keep that in mind a little bit, and the numbers kind of keep getting adjusted a little bit. One of the other numbers that they changed a little bit were deaths due to COVID versus deaths among cases, and that's trying to distinguish patients that they think died from COVID versus, you know, had COVID and maybe died from other things. So kind of trying to separate that out. That's kind of a new nuance of the last few days. But to go back to that top figure, that big kind of broad band that's coming in the dotted line in the middle, that's the actual number of infections. So a lot of people are just not getting tested or were not able to get tested at the time of when, you know, this graph was being shown. A lot of the testing in Colorado did not become available until like mid-April. So you can kind of see that there's, you know, a guesstimate that the number of cases was much higher than what we actually know about. Things opened up, and you can see that actually the number of tests kind of going up in mid-April towards the end of April as the blue line. And so you can kind of track different things. One of the other cool graphs that I'll show at the next time is it has a graph of how good we are at socially distancing ourselves, and it measures data many different ways, but electricity use at home, number of cars on the roads, and things like that. And so we're still doing really pretty good in Colorado, but, you know, you could see that there's a predicted little bump that happened kind of here in May after having maybe a drop in the number of cases with some of the openings. So not necessarily a second wave, but you know, it is one of those things to kind of keep an eye out. And again, it's a model, so it's bound to be somewhat wrong, but it gives us at least some sense of what's going on. And I think that that's very helpful nowadays to kind of see where at least the predictions are. When do we think things might open? So you might hear a lot about, you know, that the state probably may not do much really until mid-June, end of July, you know, end of June, mid-June, end of June, I meant to say. And that's based on some of these models. You can see that the number of cases maybe is shown here trailing off a little bit. So these are the models that, you know, the experts are using to kind of help guide us. And you can look at the data yourself and kind of say, hey, how concerned should I be? You can also see sort of the rates and concerns about by age. So who is at risk? What we're seeing is that it's really the elderly still. So I'll emphasize that group. Um, Patients 70 and higher, you know, definitely have sort of an increased risk. Patients 80 and higher, the risk really starts to go up. I mean, most of the deaths are occurring in that population. Some of the other comorbidities might add to that risk, but age is by itself is a huge factor. And you can see all of that for at least the Colorado cases, at least really easily. And again, that Colorado Department of Public Health and Environment has all kinds of graphs broken out by different counties, different age populations, and things like that. So again, that's coming back and will be presented again. When was that, Kelsey?
May 28th, Thursday afternoon. And we'll record that one as well if you're not able to watch it live.
Great.
We had a couple of different questions about efficacy or promise of drugs, hydroxychloroquine, erythromycin, and methotrexate.
Yeah, so some of the different treatments that are being looked at for the treatment of COVID. So the big one that really got notoriety, maybe thanks to our president, maybe more so than anything else,